enzyme deteriorated, right? It could also be that the patient had an old MI and developed aneurysm, right? And that this actually represents an actual ischemia, but this represents a scarred myocardium with an aneurysm. Those are the two possibilities. Okay? Now, what was the point I'm making? The point I'm making is that it is very unusual and almost impossible. Where is Brad? Okay. It is very unusual and almost impossible for you to have a global myocardial infarction. You don't get global. There's no way you're going to get infarction of your whole heart. It just doesn't happen. Right? Because even if you put a clip around the left main coronary, the right coronary will supply some area. You will get some infarction. So generally speaking, either you're going to have lateral infarction, arterial infarction, or inferior infarction, or inferolateral and anterolateral. You never get infarction of the myocardium where you have ST segment everywhere. Okay? So the point of this slide is to tell you one thing only, that when there is myocardial injury and there is ST segment elevation, you should look for the reciprocal changes. Because if you have global ST segment elevation throughout the EKG, that is not myocardial injury. That is the electrocardiographic manifestation of pericarditis. Okay? We'll talk about that later on today. So basically, how do you tell lateral injury from inferior ischemia, especially in patient history? You can't look at this EKG and say, oh no, patient is stable. No, if I give you this EKG and I tell you this patient just came in with chest pain and cardiac enzymes are pending, what diagnosis would you make, Justin?
If you said that he has chest pain?
Yes.
I mean, you said it, if it's global, then it wouldn't be MI.
Yeah, but it's not global. Is it global? Global means every single lead has ST segment elevation.
Oh, okay.
That's what global means.
Then I would say STEMI.
You say, exactly, you say an ST segment elevation like an infarction. That's what you say, right? If I tell you the patient is on a routine clinic visit and he had an episode of chest pain 3 years ago while he was camping in Kilimanjaro, but currently he's on a routine clinic visit, what would you say, Justin?
You said
he had an episode of chest pain 3 years ago while he was on vacation, and now he's visiting you just for a routine physical exam. He doesn't have any chest pain.
I wouldn't say it would be MI.
So what would you call it? You would say this guy has coronary artery disease. He definitely has inferior ischemia, right? And that heart attack he had, that chest pain he had a while back was actually a STEMI and may have developed an aneurysm from it. So you want to do an echo, right? So you see, tell this EKG, I can build a lot of stories around this EKG. But the point of this EKG is to tell only one thing. Whenever there is ST segment elevation that is due to myocardial ischemia or injury, ST segment elevation that is due to myocardial injury, look for reciprocal changes. Because there are leads that are in opposite direction and they will show the same thing as mirror images. That is so important because that is the only way you're going to be able to tell pericarditis from myocardial infarction. Okay? All right. Are we clear? Stephanie, you're good?
Yeah.
Excellent. Okay, so let me ask you a simple question. We're gonna see how much of what we talked about last week you retained. So, Stanley, which of the following is the complication of acute myocardial infarction? Right? Mm-hmm. Pericarditis, ventricular aneurysm, and stunned myocardium. None of the above, all of the above.
Is that pericarditis?
Pericarditis, stunned myocardium, ventricular aneurysm. None of the above, all of the above. Acute complication of myocardial infarction. Ventricular aneurysm, pericarditis. What's the third one?
I don't know.
Stunned myocardium.
Okay.
Which one is the complication of acute myocardial infarction?
I'm not so sure. I'll be honest. Yeah.
All of them are, right? Okay, so let me ask you another question. What is the commonest cause of death in the immediate post-ventricular aneurysm?
I'm sorry,
Arrhythmias. If somebody dies within 24 hours of an MI, it's a ventricular dysrhythmia or arrhythmia. The commonest cause, okay? So if somebody develops acute hypotension following MI, meaning cardiogenic shock following myocardial infarction, possible, what is likely to cause that? Cardiogenic shock following acute myocardial infarction. What are the possible causes? It could be massive MI, or it could be pericardial effusion, it could be ventricular rupture, right? Those are the things that will give you those kind of problems. I gave you a list of complications of myocardial infarction. You better make sure you understand this list very, very well, because everything I just asked you right now is on here. Every single complication is a potential question. Okay, and everything I put in there. So pay attention. This is probably one of the most important slides in this set that you have. Pay attention. Very, very important, because you can't miss this. Okay? All right. So now why is it important to diagnose pericarditis within the context of myocardial infarction? Because myocarditis is a contraindication to anticoagulation. Okay. Remember, you give patients with unstable angina heparin, right? You give them aspirin, give them heparin, right? If you have pericarditis, you can't do that. So think about a situation where you have a patient with myocardial infarction who now develops mural thrombosis. You know what a mural thrombosis is, right? It's a clot that forms over the infarcted myocardium within the ventricle, right? And then you just figure that out. You're thinking of anticoagulation. Then the next morning, say the patient was admitted with inferior myocardial infarction. With an inferior myocardial infarction, you expect XT segment elevation in 2, 3, and AVF, right? So supposing, and you expect ST segment depression in V5, V6, right? That's reciprocal changes. So supposing loss. So you are rounding in the CCU, you are the intern or hospitalist PA, and you're rounding. This patient came in yesterday with inferior myocardial infarction, ST segment elevation in 2, 3, and AVF. And now you're looking at the CKG today. Yesterday he had ST segment elevation in 2, 3, and AVF, and he had ST segment depression in V5 and V6, right? But now today he has ST segment depression, ST segment elevation everywhere, including V5 and V6. He flipped his ST segment in V5 and V6 within 48 hours of admission. What would you say? How could you explain that?
Pericarditis.
Thank you. He's developed pericarditis, and you will stop his anticoagulation immediately. And then you call whoever your cardiologist is that this guy is looking at wrong. Do you see how you need to make use of that information? Excellent. So now let's talk a little bit more about pericarditis. It's a very complicated disease, different types. It is divided into 3. There is acute pericarditis, there is incessant pericarditis, there is recurrent pericarditis, and there is chronic pericarditis. Acute pericarditis is the inflammatory pericardial syndrome. And you need the following criteria. The patient has a pericarditic chest pain, there is a pericardial rub, and there is a new, remember that keyword, new, widespread ST segment elevation. That is what we likely to see more often. Widespread. That is in every lead. You don't get that in myocardial infarction. In myocardial infarction, you get localized evidence of injury and reciprocal changes in the opposite side. When you have widespread global ST segment elevation, that is not myocardial infarction. That is pericarditis. Okay? And then something weird also happens. When you have ST segment elevation, you also get or PR depression. Acute pericarditis is the only condition on earth that depresses PR interval. There is nothing that causes PR elevation, only PR interval. And the only condition that causes depressed PR is acute pericarditis. Okay? And of course, you can find evidence of inflammation in the blood, like C-reactive protein, ESR may be elevated, white blood cell count may be elevated. There might be evidence of pericardial inflammation on CT or CMR. This one right here, they are non-specific and they're really practically useless. Chest pain, rub, ST segment elevation, or PR depression. If it's severe, you can get pericardial effusion, right? Okay, so that is acute, right? When pericarditis lasts, most acute pericarditis will be gone in under 4 to 6 weeks. When pericarditis goes on for more than 4 to 6 weeks, but under 3 months, it is called incessant. Incessant pericarditis. If it goes on for more than 3 months, it is called chronic pericarditis. If you have 2 episodes of pericarditis within 4 to 6 weeks, it is called a recurrent pericarditis. Okay, so somebody gets pericarditis, it resolves, and within 4 to 6 weeks, they come up with another episode of it. Okay, that is recurrent pericarditis. Generally speaking, we look at pericarditis as acute, incessant, chronic. Okay, 4 to 6 weeks or under, that is acute. 4 to 6 weeks to less than 3 months is incessant, and pericarditis that goes on for more than 3 months is chronic. Okay, are we good? All right. What causes pericarditis? You will not know many times. Most of the time you will not find out. But other times it is usually infectious, and a lot of stuff can cause it: bacteria, TB, viruses. And then the third leading cause of pericarditis is really post-myocardial infarction pericarditis, or when people get procedures done on the pericardium itself. And you will learn more about that. Chest trauma, like stab wound to the chest, can cause pericarditis if you graze the pericardium. Uremia. What is uremia? Okay, accumulation of urea. Usually, uremia is a surrogate for toxemia, of renal failure, right? I mean, it's not only urea that accumulates when kidneys are failing, but urea is one of the few things we measure. So when we say uremia causes pericarditis, it is really not that the urea itself is what is causing it, but the toxin that are represented by that urea in the blood can also irritate the pericardium. So it's a kind of toxic pericarditis. So the uremia is listed there. And then neoplastic diseases, primary and secondary neoplasm, then radiation therapy, So somebody can get radiation therapy for breast cancer and they will develop pericarditis. It will be called radiation pericarditis. Okay? And then you have all these vascular diseases, all right? And then I'm sure you guys talked about the echoviruses, right? So how does it present? Chest pain is key, right? Remember on the first slide I told you chest pain, pericardial friction rub, ST segment elevation, or PR depression, right? Okay. Now, the big deal is how do you tell pericarditis from myocardial infarction? Because they both present with chest pain and they both are coming from the heart. So you really have to be able to tell them apart. Okay? You don't want to confuse pericarditis with myocardial infarction. You must be able to tell them apart. So here is a table that talks about how do you tell them apart. You see how confusing it is? They are both retrosternal. Right? They're both retrosternal. They both have sudden onset. An important difference is the character of the pain. The pain of myocardial infarction is an angina. Okay? It's a pressure-like pain. Right? Whereas the pain of pericarditis is a stabbing, sharp pain. And when pericarditis becomes complicated by pericardial effusion, the pain becomes dull or actually disappears. Okay? So when pericardial effusion, remember pleuritis and pleural effusion? Right? You get a pleuritic chest pain when you have pleurisy. If you develop pleural effusion, the pleuritic chest pain subsides or the quality changes. The same thing happens with pericarditis. So that table says sometimes dull. That is only when the pericarditis is not complicated by pericardial effusion. You remember what I said about it? Okay. Changes with respiration. See, myocardial infarction does not, the pain of myocardial infarction is not pleuritic. It doesn't change with inspiration. Pain of pericarditis does. Right? Because the pericardium is what holds the heart within the mediastinum and is attached to the pleura, right? So when you get inspiration and the lung expands, the pleura gets stretched, pericardium gets stretched. So the pain of pericarditis can have a pleuritic quality, okay? Pain of MI does not have any relief with any posture. When people have pericarditis, they get relief by sitting up and leaning forward. Can anybody tell me why they feel better when they lean forward? Why do you feel better when you sit up on the bed with your hand like this? What? Thank you. What happens to your mediastinum when you're in that you have more room in the mediastinum, right? So they tend to feel better that way. Okay, these are key. You can't forget these things. That is why in the fall you guys talked about patient history and how to characterize pain and the differential diagnosis of different characteristics, right? Okay. Radiation, both of them can go to the jaw because it's coming from the heart. Myocardial infarction tends to be of short duration, pericarditis tends to be longer. Pericarditis will never respond to nitroglycerin. Okay? So extremely important that you're able to tell these two pains apart. Pericardial friction rub, this is what it feels like. Right? It's exactly, it sounds like a pleural rub. But the difference is that pericardial friction rub rhymes with the heartbeat. So it has two components. There's a diastolic and a systolic component. You have to listen to this to understand it, how to appreciate it. Okay? Just know, all I need you to know right now is that he has a pericardial friction rub. Okay? And he has that quality. So, pericarditis is the only condition that would actually cause you to have global ST segment elevation. Myocardial infarction will give you regional ST segment elevation with reciprocal ST depression in opposite leads, right? But pericarditis gives you ST segment elevation. The kind of ST segment elevation you get with pericarditis is actually different from the kind of ST segment elevation that you get with myocardial infarction. With myocardial infarction, the ST segment elevation tends to be convex. Whereas with pericarditis, it will be concave or flat. Okay? It will still be above midline, but it won't be bulging. Okay? Now, yeah, we say that, but that is very difficult to appreciate in practice. So the configuration of the ST segment itself is not very reliable. Okay? But the globalization of it, it's gold. Okay? Again, this is a table repeating everything I've just told you. With pericarditis, the ST segment is generalized or global. Whereas in myocardial infarction, it is limited or regional. You see that? Very important. With acute myocardial infarction, there will be reciprocal changes. With pericarditis, there will be none. Okay, because it's a global ST segment elevation. Again, ST2 wave changes are very common with acute myocardial infarction. You don't see them in pericarditis. You might find that by acute T waves, you might find T waves, PR segment depression is frequently seen in pericarditis. These differences are clear to you, right? Okay. Look at this is what the EKG looks like with pericarditis. You see ST segment elevated everywhere, right? Who laughed? Lost. Why did you laugh?
Love you the noise of the film.
Huh?
Take a photo of you.
I took it. What are you saying?
We all laughed. Someone took a picture.
Somebody screenshotted and made the sound of a shutter.
Because I took a picture of this.
Yeah.
You see, just took a picture of me. Are you taking a picture of me? I didn't sign a waiver. I'll sue this class. There is something. There should be a problem on it. Somebody should spot something on this EKG that is a little bit weird. Is the ST segment elevation truly global on this EKG?
No.
Good. Where is it not global? Where are you not seeing it? Good. You don't see it as convincingly in 3 and B1, right? Right? So, when I say generalized global, it doesn't mean in all the leads. It means in most leads. And it does not have a pattern. You understand what I'm saying? Okay. So when we say it's generalized, it does not mean you will see it in every single lead. It just means that it will be diffuse ST segment elevation. Diffuse means not specific. Remember, when you have a heart attack, you gotta have an inferior MI, in which case you will show evidence of injury in lead 2, 3, and AVF. Or you have it in the anterior wall, B1 to B4, or you get it in the lateral leads, in which case you can see it in ABL, B5, or B6, right? So, for myocardial infarction, we get this regional ST changes, elevation specifically. But in pericarditis, the ST segment elevation is diffuse, so non-specific, and specifically does not have reciprocal changes. Where you would normally expect reciprocal changes is in the inferior leads and the lateral leads. And you can see that they're both elevated in 2 at least, and ABM. 3 is not playing along here, right? But at least 2 and ABM show it, right? And you can see it's also elevated here. Do you see the difference? Can you appreciate it? If I give you this in an exam, you can spot this right away. Okay. And by the way, you know I told you that for EKG, I needed to read EKG in 10 seconds, right? I want you to realize how easy that really is. So I show you an EKG. Immediately you just say, axis is, rate is that, rhythm is regular, the orientation is normal, P wave is normal height, normal width, QRS duration is normal. You have a template, just keep talking. You don't have to wait until you have scanned the entire EKG before you talk. Start talking. Think and talk. That is what I mean. And in 10-15 seconds, you should be done with the EKG. You need to practice that. And also, did you see the PR segment depression? You see that? Did you see that? That is PR segment depression. How do you know when PR segment is depressed? To start with, how do you know when ST segment is elevated? You compare it to PR, right? Okay. So how do you know when PR is depressed? You compare to PT. Right? So you compare. So the only way I know this is depressed is because this is the PT line. This shouldn't be below this PT. It should be at the same level. This PT, PR, and ST should be all isoelectric line. Right? So when you see PR is sagging before the line before the P, that shows you that PR is sagging. So it's that sagging PR, which is a less obvious sign, but many people ask it in exams. I don't know what's up with that. Okay, practically of no significance, but it's heavily tested. So don't forget it. Okay. So when you see somebody with elevated pericarditis, you do your blood count, you might see leukocytosis, you might see elevated BUN creatinine. Because whenever the pericardium is inflamed, the underlying myocardium shares in that inflammation. So it is often possible for you to have slight elevation in cardiac enzyme. Okay? So you will get elevated cardiac enzymes. And you will see evidence of inflammation, acute phase reactants like ESR, C-reactive protein. And if you're strongly suspecting virus, you might send for viral serology, but we don't do all that. Before you get your viral serology back, your patient has recovered. And how do you even treat pericarditis? Aspirin. Just give the patient aspirin. Okay. If it's pericarditis, will get better. If it's not, they won't. Right? Okay. But for exam purposes, you have to know that you do blood count and you do acute phase reactant. What is normal ESR? 10%. No, actually yes, 10 to 20 young people. Adults, your ESR is about your age. So if you're 60 years old, your ESR will be about 60 per hour, right? If you're 70, it will be about 70. It kind of increases with age, okay? Okay. So diagnosis, you see, once you have your criteria, chest pain, rub, EKG changes, or you have regular infusion, hey, see what you do. Aspirin or colchicine, anti-inflammatory, that's all you do. And you restrict exercise. Why do you want to restrict exercise? Why do you want to restrict exercise in somebody with pericarditis?
heart rate, so you
You want it to
force the
rest.
heart.
Exactly. You want the heart to do minimum work. Because remember, pericardial inflammation is an inflammation. If you make the heart do a lot of work, you're causing a lot more bruising. You're likely to create hemorrhagic pericardial effusion and just cause, so you put the patient on absolute bed rest. Okay? It is only when NSAIDs and exercise restriction does not work that you give the patient low dose corticosteroids. Okay? If your patient recurs with pericarditis, you have to, again, you treat it exactly the same way. So this is a big table of nothing. Okay? NSAIDs, that's all you do. Anti-inflammatory with colchicine and rest. They recur, you do the same thing. Low dose corticosteroid, they're not responding. But before you give anybody steroids, make sure you rule out infection. Because steroids work by depressing your immunity. So if you depress somebody's immunity when there is an active infection, you are on the side of the bug. You're going to kill the patient. Okay? And then if that does not work, then you now use all these heavy-duty immunosuppressants like IG globulin, azathioprine, and push comes to shove, you can't get the infection to go away. You strip the heart of the pericardiectomy. Okay? Anyway, so basically, how do you do pericarditis? NSAIDs, with or without steroids, depending. Right? Now let's talk about pericardial effusion. Pericardial effusion is a complication of acute pericarditis. Okay? And basically it just means fluid forms within the pericardial space. So the heart is now swinging in this bag of fluid. And then when you look at the EKG, what do you see? Electrical alternates. Right? Okay. How does it present? See that? Precordial chest discomfort. Usually disappears, but may occasionally persist. Typically speaking, when the patient develops pericardial effusion, the chest pain disappears. The patient now has a discomfort, like a heaviness, not pressure, like a heaviness. They actually feel the weight of the effusion. Right? So you see, an articulate patient will tell you, I feel heavy in my chest. Right? Okay. Is it possible, Christian, is it possible for you to have, what will happen to the pericardial friction rub in an effusion?
It would go away.
Thank you. Because the effusion, the rub is from the two visceral and pleural rubbing against themselves. Once you have an effusion, you separate those two. The pericardial rub goes away. Exactly the same thing as in pleurisy and pleural effusion. Remember that? Okay, good. So what is an ECG? Electrical alternates, right? Okay. And you see this chest x-ray? The heart becomes globular. It becomes like a ball. Under normal circumstances, if you look at the chest x-ray, the heart looks like football. American football. When you have pericardial effusion, it looks like Mexican football. Right? Okay. It's a globular heart shadow. Okay? How do you treat this thing? You have to get rid of that fluid. So what we do is we get a big bore needle, right? You get a big bore needle. You attach an electrode to the hub of the needle, and you go through the xiphoid process, and you keep pushing that needle up with a gentle negative pressure. Once you hit the pericardium, you will see a blip on the lid. That means you've hit the pericardium. You now go in 1 more inch and you see the infusion, fill your syringe, and you take out as much as you can. It's a very simple procedure. Okay? So this is exactly how you do it. You collect the fluid and you take a good look at what kind of fluid are you getting. Many times when it is viral infection, the fluid will be serious. If it's a bacterial infection, it will be virulent. If it is TB, it will be caseous. If it is malignant, it will be chylous or hemorrhagic. So the character of the fluid itself can give you an idea of what is causing this effusion. But you don't make a diagnosis based on visual appearance. You always send it for microscopy, culture, and sensitivity. That's what MCS is. And they also send it for cytology. Okay? All of this is just trying to figure out what the heck is going on. Okay? Because pericarditis is likely to be chronic when it is associated with effusion. Okay?
Say that again. Pericarditis.
Pericarditis is more likely to be chronic when it is associated with pericardial effusion. All right, so you treat your pericardial effusion because pericardial effusion is a complication of pericarditis, right? So you treat the pericarditis like you always do, anti-inflammatory. If you identify a bug, you use antimicrobial. If it's bacteria, you use antibiotic. If it's TB, you use anti-TB. If your cytology returns positive, you send them to oncology, they give them cancer drugs. If you can't find anything, you fuse the pericardium. Right. Remember how we fuse the pleural? You fuse the pericardium. When you fuse the visceral and perineal pericardium, that is called pericardial sclerosis. Okay? But supposing the patient has had this pericarditis for a long time, they're coming to you from Egypt, rural part of Egypt. And you know who Imhotep is? Who? Imhotep.
Imhotep?
Imhotep. No? Okay. Look it up. That's the guy that trained Socrates. He's an Egyptian. All right. You need to know these things. If you don't know your heritage, people will steal it. All right.
No, you know this stuff? Egyptian, bro. What's up?
So, but supposing the pericarditis has been going on for a long time and it's already chronic, you can't fuse it, right? Because it's already fibrosed, right? That is when you have to do pericardiectomy, you strip it, or you put a hole in it so that the fluid can just drain out and then give the patient it back. Okay? So they carry a pericardial back and the fluid just drips. That usually is a stopgap measure while they're waiting to get pericardiectomy. Okay? So you see that pericardial effusion doesn't have any unique treatment. It's a treatment of the cause. Right? Pericarditis and whatever else is causing the effusion. Cancer, bugs, whatever it is, you treat it. Okay? Excellent. Any question? Moving on. Now, why do we worry about pericardial effusion? So, pericardial effusion is a complication of pericarditis. Pericardial tamponade is a complication of pericardial effusion. Okay? Understand that? So pericardial effusion with tamponade, what does that really mean? What is tamponade? Tamponade means the fluid is now under pressure. See, under normal circumstances, a patient develops pericardial effusion. And the effusion, once it attains a specific volume, stabilizes because the rate of formation and the rate of removal equilibrates. When you have massive pericarditis or hemorrhagic pericarditis, where the patient is not just effusing from inflammation, they're actually bleeding, then the fluid, the pericardial effusion fluid, gains pressure. When the pericardial effusion is under positive pressure, tamponade sets in. Let's think, how do you know when somebody has developed tamponade? The blood pressure drops. The neck veins become distended. The heart sound distant. Those three clinical criteria is what Beck's described. Beck, actually, is known as Beck's triad. Now let's talk about, and of course this is not new to you, right? This is electrical alternates, right? So tamponade gives you a restrictive cardiomyopathy. What do we mean by a restrictive cardiomyopathy? This is what happens. So when there is positive pressure around the heart, when there is positive pressure around the heart, that means the ventricles cannot dilate. Right? If the ventricles cannot dilate, that means the left ventricle cannot receive blood. If the left ventricle cannot receive blood, then it can't pump out blood. So the left ventricular cardiac output drops. That is why the blood pressure drops. The right ventricle cannot dilate. So the right atrium cannot empty because the right ventricle cannot receive the blood. If the right atrium cannot empty, it can't take blood from the superior and inferior vena cava. Right? So that is the reason the neck veins are up. Right? And the reason the heart sound distant is because now it's like you sound underwater. The heart sound has to travel this fluid to reach the chest wall, so it sounds muffled and distant. Right? But that is not all. With that in the back of your mind, think about what now happens when the patient inspires. So, stop writing, listen. The right and the left ventricle are being compressed, so they can't dilate. That is what makes it restrictive. When the patient takes a deep breath, you create a negative pressure in the chest, right? You enhance venous return to the right? And you diminish it. You diminish it to the left ventricle, right? Already, they are restricted. But now with inspiration, you're enhancing venous return to the right and you're reducing it to the left. So the right ventricle feels more than the left ventricle and displaces the septum into the left ventricle, compromising even further the left ventricular filling. And that results in a further decrease in the cardiac output from the left. When cardiac output drops, basically what drops is the stroke volume, right? So when that drops, what happens? The systolic blood pressure drops some more. and the heart rate increases because the sympathetic nervous system wants to make up for the cardiac output, right? That increase, so that fall in the systolic blood pressure by at least 10 is what is called pulsus paradoxus. Okay? Now let me ask you, did you understand everything I just said?
Mm-hmm.
Okay.
Pulse also decreases.
Yeah. What is happening at first is a decrease in stroke volume and a real increase in the heart rate. Because that's what makes it. That's what the body should do. Anytime cardiac output drops, what the sympathetic nervous system will do is to actually increase the heart rate to make up the cardiac output. That's what they do. And the systolic blood pressure will drop by about 10 millimeters with inspiration. But then we call it pulsus paradoxus. Pulsus paradoxus is Latin for paradoxical pulse. There is a reason for that confusion. You see, when pulsus paradoxus was first discovered by the fathers of medicine, they had no sophisticated equipment. There was nothing like systolic blood pressure. We were just managing to learn how to measure blood pressure at that time. It was determined purely on the patient's pulse. Right? Now, I want you to put your right finger on your left radial pulse. Can you feel your own pulse? Now, I want you to pay attention to the rate of that pulse right now. You have an idea of your own pulse rate now, right? Now I want you to exhale maximally and then take deep, slow breath. Tell me what happens to that pulse. It increases. Thank you. That is normal. Because the cardiac center and the respiratory center are very close in the brainstem. So the impulses of inspiration spread to the cardiac center. So generally speaking, inspiration increases your pulse rate. That is what is normal. And the reason that you felt it is because every single stroke volume elicited a peripheral pulse because it was a normal stroke volume. Right? When there is pericardial tamponade and the septum from the right ventricle is pushing the septum into the left ventricle, compromising the left ventricular filling, diminishing the stroke volume, not every left ventricular output elicits a peripheral pulse. And because that is worse with inspiration, the pulse decreases with inspiration instead of increasing. That's why we called it pulsus paradoxus. Do you understand it? But doctors, healthcare providers, physicians, clinicians have become so technical. We have lost finesse. We depend so much on technology now that we now define pulsus paradoxus by a drop in systolic blood pressure by at least 10 with increase with inspiration. Whereas what the fathers did was to define it by the decrease in the pulse with inspiration. And that was why they called it pulsus paradoxus. If you look in many textbooks, they don't even talk about the absurdity of calling it pulsus paradoxus and determining it by blood pressure. That's an anomaly. Because pulsus paradoxus is paradoxical pulse. Something weird is happening at the pulse. There is a decrease with inspiration instead of an increase, which is what the paradox is. But because we have become lousy clinicians, because everybody says, hey, it's there, it's not there. It's like a third eye sound. I heard it. No, it's a split second. I know it's a third eye sound with eye view. And when we publish and we do studies, we want to be sure, we want something more concrete. So that was why they redefined falsus paradoxus as a fall in systolic blood pressure of at least 10. Now you understand what falsus paradoxus really is, and you know how it is determined, and you know what it really means. Okay? Excellent. Any questions? Good. How do you treat pericardial tamponade? Pericardiocentesis, but not routine. It's emergent. You do it like that. If you don't, the patient will die. Okay? So that is a big deal. Again, you go like I just told you. This I can't teach you in the classroom. The same thing. You get a big body. Of course, there are pericardial synthetic needles, but much longer. You always put the lead on the metal part. The idea is so you know when you hit the pericardium. Okay? When you hit the pericardium, you get an injury current. That injury current is going to be an ST segment elevation in that particular lead. Okay? And then you get it out. Now your patient is fine. Okay? So now we talk about pericarditis, a very simple condition. It can be complicated by pericardial effusion, and then the effusion can become tamponade. Right? Treatment is pericardiocentesis. Routine, in a routine effusion, emergent in cardiac tamponade. Got it? Okay, so let's talk about constrictive pericarditis. So you know that in acute pericarditis, you can actually get fluid forming in between the visceral and parietal pericardium and separating them. But if the inflammation has been on for a long time, and then you get chronicity, fibrosis, the pericardium becomes so thick and becomes a case, an actual case, encasing the heart. When that happens, we call it constrictive pericarditis. Okay, it's a chronic pericarditis with thickened fibrotic pericardium, usually following radiation, histoplasmosis, and TB. What is interesting is that sometimes constrictive pericarditis can coexist with cardiac tamponade. Right? So in other words, you have an acute pericarditis, the two pericardia get inflamed and they are separated by fluid, but the inflammation is still going on. So on their own they get thick, and thick. So you have this thick pericardia separated by the fluid, and that is unusual. Okay? That is what we call an effusive constrictive pericarditis. Okay? How do you know when somebody has developed effusive constrictive pericarditis? In other words, how do you know that this patient has developed effusive constrictive pericarditis? Remember, what causes tamponade under normal circumstances is fluid under pressure. If you drain the fluid and the patient is still exhibiting evidence of tamponade, that means whatever is causing the tamponade is not drained. Right? So the diagnosis of effusive constrictive pericarditis is in hindsight. It's a hindsight diagnosis. You can never know going in. The only way you know is that you took out the fluid and the chambers are still very high pressure. The patient is still having symptoms of tamponade despite pericardiocentesis. Then you know, okay, now the heart is getting constricted by the fibrous tissue. Okay. So that is how you now say, okay, this must be an effusive constrictive pericarditis.
Is it a short one?
Well, the truth is, tamponade is usually taken out the fluid, the patient is still showing tamponade physiology, then you know this is an explicit constricted. Then if you send it for MRI and do echo, you will see it. But in the acute setting, you won't have time to evaluate it like that. Right? So, constrictive pericarditis. Constrictive pericarditis. It presents with heart failure, but it has a right-sided emphasis. So the patient has a congestive heart failure, but the right heart failure is way more than the left. So they don't get shortness of breath, they don't get too much autopsia, they don't get PND, but they get this serious edema. And that edema tends to be mostly around their trunk. And it's not fat, it's water. Okay, so you get congestive heart failure with a right-sided emphasis. A right-sided emphasis begins with pedal edema, severe ascites, gastrointestinal congestion that gives you dyspepsia, remember? And then the hepatic congestion that gives you the right upper quadrant pain, right? And because the pericardium is now like a case, instead of the heart swinging in a bag of fluid, it's actually knocking on the inside. So you begin to get not a rough, an actual knock. Right? It's like the heart, and that knock is coming from the heart banging the inside of the fibrous pericardium. And what is crazy is that sometimes the fibrosis is accompanied by calcification. So you can actually see calcification. The heart shadow can be outlined by calcium because of the calcification in that pericardial tissue. All right? So you get this congestive heart failure with right-sided emphasis and then a pericardial knock. This is what the patients look like. And then, with constrictive pericarditis comes this thing called Kussmaul's sign. What is Kussmaul's sign? Jugular vein distension during inspiration. What should happen to your neck vein when you inspire? Ali. When you inspire, should your neck vein collapse or distend? Under normal circumstances, once you inspire, you create negative pressure in the chest, right? You increase venous return, right? If everything is well, the right ventricle dilates, the right atrium dilates, so your neck vein should collapse. But if there is a restrictive physiology, something that is not allowing the heart to dilate and receive blood with inspiration, what happens with inspiration? Neck vein distends, right? The distension of neck veins during inspiration is abnormal, and that is what is called Kussmaul's sign. Okay? Reversal of normal pattern of decreasing jugular venous pressure during inspiration, classically seen in constrictive pericarditis because of normal increase in venous return with increase of abdominal pressure from diaphragm contraction, yada yada yada, all this long story. Bottom line is the inspiration, negative intrathoracic pressure, neck vein will collapse normally, but when that increased venous return cannot be accommodated by the constricted heart, the neck veins can empty, so they distend. And that distension with inspiration is abnormal. It is classic for constrictive pericarditis. Somebody should ask me, why don't we see Kussmaul's sign in tamponade? Yeah, Carol. Shouldn't we see it in tamponade?
Push the septum, right? So it makes states, right? So.
In tamponade, why don't we see it? I mean, remember the same tamponade physiology, right? Restriction, right ventricle can dilate.
There's fluid. I mean, the tamponade is fluid. And putting pressure versus this is actually fibrosis. It's hard to move tissue than to move fluid.
That is one reason, but there is another simpler explanation for it. What is Beck's triad? Muffled ultrasound and this thing. So the neck veins are already maximally distended. They are already to the angle of the jaw. So how much more? It is not that it's not happening, it's just not visible. Because in tamponade, you have jugular venous distension already. So with inspiration, you can't really appreciate the distension or the elevation with inspiration by the bedside. You understand what I'm saying? So, but in constrictive pericarditis, because they're not in tamponade, inspiration will bring it up. Okay? So don't get confused. Kussmaul's sign is not a sign of tamponade because the jugular veins are already distended. Okay? If tamponade is early, and the neck veins are not maximally distended, you will find a positive Kussmaul sign. But that is an exception, not the rule. Okay? Don't get confused. It's an exception, not the rule. See what I was telling you? This is the heart. See the heart encased in the calcium shell? That is not normal. See that? Right? So whenever you see this on a routine chest x-ray, that patient has had a pericarditis. You can do chest x-ray for a positive skin test, TB skin test, and you can come back with this. That means that patient not only have they had TB, they've actually had tuberculous pericarditis. Okay. So whenever you see this, it's a sign of constrictive pericarditis. See what surgery can do. Because think about it. If the heart failure they get is with a right-sided emphasis, that means the only treatment. How do you treat right heart failure? Diuretics. That's it. Diuretics, diuretics, diuretics. And diuretics have some terrible side effects, right? So invariably, we just use diuretics and we stack it. So we use combination diuretics. So you block the loop, you block the distal, you block the collecting duct, you block everything blockable. You stack the diuretics, right? Remember diuretic stacking? Whenever I use diuretics on top of themselves that block different segments of the nephron, it's called stacking, right? So for the treatment of chronic constrictive pericarditis, it's aggressive diuretic therapy with combination diuretics, furosemide plus metolazone plus spironolactone. Before and after the removal of the pericardium, see what difference it can make. This guy has had surgery. This guy he went from 160 kg to 93 kg. See what difference this can make, surgery can make, right? How do you treat effusive constrictive pericarditis? Just as acute pericarditis. Okay? Remember I told you effusive constrictive when the signs of tamponade persist? All right. Good. I'm in good shape. Any question? You're good, right? All right. So,
So if you give the diuretics, what do you know to
diuretics, you see the diuretic you're going to give. You're going to give a loop, a distal converted tubule blocker, or a lactone, collecting duct blocker. Patient can, this is not sustainable. Patient cannot live normal life with that. You're going to spend half of your day in the bathroom. So you use that to relieve the symptoms while you schedule the patient for a workup for the surgery. Okay, so it's not supposed to be forever. But generally speaking, in South Central, our patients are going to be years on diuretics until we beg and plead for them to please get the surgery somewhere. Okay. All right, so I'm going to give you 5 minutes break because we're going to switch gear now to cardiomyopathy and other stuff. We have a lot to cover. So go. 5 minutes precisely.
Where the ischemia is. They need
the group leads. That's why we call them contiguous leads. Leads that together make sense. All right, so I'm going to ask you a question. I've been using this word, and I was hoping that everybody understands it, but I want to make sure. I keep saying that ST segment elevation, it will be regional when it is due to myocardial infarction, right? And it will be general when it's due to pericarditis. And general means global, mostly. Not in every lead, but in most of the leads. When ST segment elevation is due to myocardial injury, you will see it in a region. And the way we define a region is in contiguous leads. So contiguous leads are a group of leads that make sense. For instance, 2, 3, and AVF are considered contiguous because they reflect what is happening on the inferior surface of the heart. B4, B5, B6 are contiguous because it tells you what is happening on the lateral side of the ventricle. B1, B2, B3 are considered contiguous because it tells you what is happening in the anterior wall, right? So pay attention. Not continuous, contiguous. All right, so I'm going to move now to a bunch of questions, which I should have done before you guys left for break, but we're going to rush through this like quickly. What is the most appropriate next step in the evaluation of a 55-year-old male hypertensive with a 3-month history of vague, sporadic chest pain, usually associated with some shortness of breath? Physical examination is unremarkable. EKG is shown. What is on this EKG? Good. Remember what I told you? Interpreting EKG, go sequentially in order of arrows. If you keep calling out stuff like that without going through arrows in the back of your mind, you will miss something. Okay? Yes, ST segment depression. So what would you do? What would you do? Where is Eden? She's not here. Okay. All right, yeah, what would you do? What would you do for this patient? Would you do angio? Would you do coronary calcium score? Would you send him for stress test, stress echo, or would you do a pharmacologic nuclear stress test? He's 55 years old, he's hypertensive. This is the EKG. And on the EKG you can see inferior lateral ischemia, right?
Echo?
Why? Why?
Stress test.
Yes. Why would you do echo? I mean, stress echo is when your patient cannot do regular stress test and there is no nuclear medicine facility. Remember, stress echo is not the best thing to do. Okay, unless you're in Burundi. Okay, so standard stress test is what you do, right? Because EKG is fine, right? Because remember, when you do stress test, what you're looking for is ST segment elevation, right? Right? Okay. Is there anyone here? You will not do coronary angiography because you have to have an indication for coronary angiography, right? You will not do calcium score because the calcium score just tells you there is atherosclerosis. It doesn't tell you there is obstructive atherosclerosis. So it doesn't tell you that that atherosclerosis is responsible for his pain, right? You cannot do stress echo for reason we just talked about. Pharmacologic stress test is what you do when your EKG is unreliable and you have a nuclear medicine facility. So what you do here is standard stress test. Okay? All right, so a 48-year-old woman with no significant past medical history presents with 2-week history of chest pain, consistently precipitated by exertion and relieved by rest. Physical examination is unremarkable. Electrocardiogram shows 1.5 millimeters ST segment depression in leads B5 of B6. Myocardial perfusion scan reveals anterior wall perfusion defect, but a subsequent coronary angiogram demonstrates normal coronaries. What is the diagnosis?
No.
What is the most likely diagnosis? She has classic evidence of angina, even showed perfusion defect, ST segment depression, and then you do the angiogram and the coronaries are clean. What is the diagnosis? Speak up. Say it again. Prince medal. Prince medal is vasospasm. Yes, that is possible, but Prince medal is not here.
The one where they don't have the classic, when they have the symptoms but you don't see anything.
Yeah, what is it called? Cardiac syndrome X. You said it? Were you saying it in the back of your voice? That's why I said speak up. Cardiac syndrome X. Right? It is not an acute coronary syndrome, because if there was an acute coronary syndrome, you would see a background atherosclerosis. Right? The fact that the coronaries were clean means it's cardiac syndrome X. And basically what it means is that what is causing the problem is in the small, tiny coronaries that you can't see the obstruction in them because they're too small. Okay? So remember that. I listed these things. Remember these things. I'm telling you. All right. What is the most appropriate next step in the management of this 52-year-old male hypertensive smoker with this EKG? Down at the ER for chest pain, vital signs are normal. Patient has been given aspirin, Plavix, and heparin bolus. The closest hospital capable of PCI is 4 hours away. So you are in Mississippi, rural area of Mississippi somewhere. Anybody from Mississippi here? Okay, anybody from Louisiana? Okay. Okay. Anybody from Appalachia here? Okay, fine. You're in a rural area of America. By the way, there are rural areas in this country too. I need to figure out specific communities. So, PCI cannot be done for 4 hours, even if you find a guy. So here is a guy with chest pain, and you see this EKG. What is on this EKG? Forget Arabic, just tell me what is here. ST elevation with reciprocal changes, right? So this guy is having major MI right now. And you can't do PCI. Thank you. You have to do thrombolytic therapy, right? Okay, good. Remember that. That is very important. But wait a minute now. Thrombolytic therapy. Why not blood draw for cardiac enzymes?
Because you already know that he's having some sort of injury. Why would you need to do it again? You need to treat the guy.
Just confirmatory.
How do you diagnose MI?
Cardiac enzymes.
Don't be too aggressive. Right? You cannot diagnose myocardial infarction without enzymes. EKG tells you injury. Thrombolytic is for myocardial infarction, not myocardial injury. Are you following me? Thrombolytic therapy is for myocardial infarction, not myocardial injury. EKG shows myocardial injury. Yes, most likely there is infarction going on as well, but you don't have evidence of infarction until you run cardiac enzymes. All right?
Yes.
Good. Y'all with me, right?
Yeah.
Okay. Now you know why it's not thrombolytic.
Yeah.
Okay. patient has been given everything that we needed to have earlier. All right? Okay, I'm glad that you're making these mistakes now. A 68-year-old woman with no significant past medical history presented sudden onset chest pain and shortness of breath shortly after burglar alarm went off in her store. Physical examination is unremarkable except for blood pressure of 150/78, pulse rate of 102 per minute. EKG shows more than 2 mm ST segment elevation in B5 and B6. Serum troponin level I is slightly elevated, but the subsequent coronary angiogram demonstrates normal coronaries. What is the most likely diagnosis? Stress-induced cardiomyopathy, right? What is it called in Japanese? Okay. So you got that, right?
Yeah.
Yeah. You see, this is an acute response to stress, right? Good. Good. What additional treatment after morphine shot and oxygen may be considered appropriate for this patient who walked into ER 2 hours ago with persistent chest pain? Look at his EKG. What would you give him now? What is going on here? What is this? What is the diagnosis? Let's start with. What is the diagnosis? Is it angina, unstable angina, stable angina, myocardial infarction? What is it? The fact that the guy got morphine. Do you give morphine to stable angina? So the guy has unstable angina, right? So how do you manage unstable angina? Bananas, right? So it's all of the above. Okay? Unstable angina, you don't need enzymes. You treat the patient. Right? You reduce myocardial oxygen demand, you increase coronary blood flow, you do everything. And you do. Alright? The only difference between the way you manage unstable angina and MI is ACE inhibitors. Right? So, banana, remember that? Yes.
Oh, the statins is in banana?
Yes. That is actually the S in bananas. Right.
Bananas.
Good. All right. Moving.
Martin, sorry, please, quick question. So for that question, if we didn't have the morphine, it was just giving morphine, how else would we differentiate that from stable from stable?
Stable, then you don't need to give them up because stable will respond all the time to nitroglycerin. The chest pain goes away with nitroglycerin for stable engines.
So we would need clinical detail to be able to answer that.
Yeah, I mean, the question, they said the guy walked into the emergency room like that 2 hours ago. How long does it take nitro to work if it's going to work? Less than 5 minutes, 3 to 5 minutes. So if 2 hours ago the guy is still having his chest clocked like that, then your nitro is broken. Your nitro is not working. That is when it switches over. Because remember, after 2 hours, you would have had 3 doses of nitro. Right? And that is why with unstable angina, you don't give them something, well, you give them nitro free. Right? Okay, so let us switch gears.